the next lecture has a lot to do with hyperplastic breast changes. And I'm not going to go into the details again about the NDs. Dear colleagues, we are going to talk about papilloma. Papilloma can cause a lot of headache for the poor radiologist. And there are some areas, some cities, where there are more cases with papilloma. Very rural areas have few papillomas. If we are looking at the answer to the question, what is the most frequent hyperplastic breast change that tries to fool us? Of course, it's fibrocystic change. And in a decreasing frequency, fibroadenoma is going to be the next. And then comes papilloma. This is the major lactiferous duct basement membrane. And we know that right under it there is the myoepithelial cell layer, and right under it there is the one-layer epithelial cells. But it may happen that, for whatever reason, a papilloma develops, and that kind of a broccoli-like proliferating tissue is going to have the same cells on the surface. You can imagine the rest. Inside, there is a very fine, very delicate connective tissue. But the whole thing lives because of this, namely blood vessel. MR experts, watch out. MR may have a washout effect in a tiny little spot, and it turns out to be papilloma, fibroadenoma, or intramammary lymph node. Now, this explains why the papilloma is so positive on MR. And the following can happen. Through these cells, either the blood or serum can get through, resulting in, sooner or later, bloody or serous nipple discharge. Why? Because surrounding the duct, there is the elastic tissue, like kind of a rubber band. And if you tease it too much, that is distending and distending further and distending further, then the rubber band is going to contract and it spits out the fluid. That's one important thing to keep in mind. And then you do galactography because you're smart. Then you are going to get the papilloma as a filling defect. Here is the contrast media. So here is a filling defect. But there is another thing to think about, namely, this blood supply may just disappear. This connective tissue doesn't get blood supply. Very dense, called hyalinization. And hyalinization always leads to calcifications. Although within a duct, they may be a cluster, crushed stone-like calcifications. If we are really lucky, then it becomes big chunk, nearly popcorn-like calcifications. And then we don't have a problem. And then I'm going to ask a very important question. What if I'm doing core biopsy on this? And the pathologist says this is an entirely benign papilloma. Should I leave it there or not? Now, the question, of course, has to be extended with more information, namely, if she has bloody nipple discharge, it's not you who is going to decide whether it should be surgery or not, because she doesn't like it, and she believes it's a cancer, so there will be surgery. But that's not what I'm talking about. What I'm talking about is that the aging lady develops a tiny, smaller than 10 millimeter, ill-defined lesion. And then you do the core biopsy. And then the diagnosis is totally benign papilloma. Should I go to surgeon or not? I will give you the results of a very nice scientific trial we did with Dr. Todd. I can tell you already now, you have to also ask the pathologist, was there any epithelial cell proliferation, atypia, lobular cancer in situ? associated to the papilloma? If the answer is no, and there is no bloody nipple discharge, then you don't need to take it out. We studied 140 cases with simulation. All of them went through large section histology, 1 centimeter from the papilloma, 2 centimeters from the papilloma. And we found out and concluded that 80 out of 140 did not need biopsy. It would have hyalinized anyway. In order to decide no surgery, you need to rule out any kind of epithelial cell proliferation on the step wedge. If there is LCIS, if there is carcinoma in situ or atypia, you have to operate. Let's start. And it's going to be very didactic because it's so complex. I make these subgroups. The papilloma is demonstrable mammographically but not palpable. And there is no nipple discharge. And there are calcifications associated. I know what kind of calcification could be. I just talked about it. Smile, coarse, hollow, popcorn-like calcification. Thank you. Welcome back next screening. Welcome back next screening, please. Papilloma. But then, there is a crushed stone-like. And I'm not going to be able to distinguish from grade 2 in situ AAB. You know this. I should not spend too much time on this. This was a godsend, the development of 14 gauge or even larger bore needle biopsy. Watch out for this, which is associated, can be beside in TDLUs. Here is the papilloma, can be beside, can be within the papilloma. Papilloma without atypia, no need to go to surgeon. Yes, here. When it's associated with grade 1 cancer in situ within the TDLU, LCIS, or it may be associated with a well-differentiated, moderately differentiated invasive carcinoma. Calcifications are associated, no nipple discharge. So this is the second chapter. Now, you think that these are within a TDLU, but at the same time you see an ill-defined density surrounding it, question mark, question mark, question mark, because this is bullet-shaped, could be malignant. In these cases, we really have to arrive at the diagnosis. Some of these cases are from the time before the core biopsy was invented. We have complete histology, hyalinized, partially calcified, benign papilloma. 75. There are two things to analyze here. The density, which is ill-defined. Microlobulated. Don't like it. Ignore the density. Look at the calcifications. Anxiety level goes up. We had to remove it surgically. This was before the era of core biopsy. No atypia, no cancer, partially hyalinized, partially calcified papilloma. This is the hyalinization. Ground glass-like, structureless. And here is the calcification. The trick in this case is that I had access to the previous mammogram. There was a non-calcified, oval-shaped, ill-defined density. Now it calcifies. Bingo, this is not a cancer. Cancer starts like this, and then later on comes the tumor mass, which also dissolves some of the calcifications. This is going to be a papilloma. Partially hyalinized papilloma. This is tricky. No radiologist can solve this problem. She has these funny calcifications in the lower half of the breast, diffuse, bilateral. And you want to put them into ducts. Well, the best idea you can come up with is that these could be skipping stones. But they didn't have any blood vessel. 11-gauge biopsy, hyalinized papilloma, and a lot more papilloma without calcifications. You don't like circular lesions, oval-shaped lesions, and you don't like when they are multiple. Could be papilloma, and in this case, the bridge among them is duct distended by fluid produced by the papilloma. I don't like this kind of surgery. Multiple papillomas, no associated atypia. Cluster discernible. I would really like to read this like this. What is this? Is this casting type calcification or look like casting? Why not in a larger area like this? Why is it hollow? Why is it so high density and even in density? Well, nobody says that it's not formed in fluid. And the fluid can be produced by papilloma and carcinoma. So let's look at it. Partially calcified benign papilloma, which used to bleed, and old blood calcified. This is calcified blood. Oh, how tricky. Poor radiologist. Do you see the distended ducts? Yes. You see one long calcification? One long calcification is not a casting type calcification. It may be a partially calcified blood produced by the papilloma that produced so much fluid that it distended the ducts too. We start to have fun. It's demonstrable on the mammogram. Calcifications are present, but there is a new guest here. Nipple discharge. And this is the nipple. These are retroareolar, very distended ducts with two clusters of crustone-like calcifications. So I don't know. Grade 2 cancer in situ. Wait, there is nipple discharge. So then I really enjoy that these calcifications are within the ducts, within benign papillomas. Even more interesting. Well, we don't favor the inverted nipple, but this is definitely a retroareolar duct that is extremely distended. And there is a group of calcifications here. And she had nipple discharge. We filled it with contrast media. The interesting thing is that you can fantasize that this long calcification kind of hanging outside is actually a papilloma going into the side branch too. Like this. Indeed. Multiple partially calcified benign papillomas. '74. Serous nipple discharge. How tricky. Why is it so that the duct doesn't go in this direction deep? No. It just decided to kind of dive down, and here is the skin. And here is a identified lesion with God only knows what kind of calcifications. Contrast media is there. Could this be a partially calcified papilloma? Definitely. So when the surgeon took this out, then I held the specimen against a very strong light. This is my methylene blue I injected. And the lesion is here. The calcified lesion is there. So we can outline everything for the pathologist where the lesions are. Benign papilloma. Do you see this distended duct with very tiny calcifications? And she has nipple discharge. Thank you very much. The multiple calcifications are sitting in multiple papillomas. Only the pathologist can tell whether they are benign papillomas or malignant papillomas. Do you see a tiny cluster calcification? Sure. One of them is pointing in this direction, the other one in this direction. Are these crustones? Are these short castings? Fortunately, they are within the filling defect and galactography. Do you see what is not visualized here by the contrast media? Distended duct. And that's where the calcifications are. Partially calcified papilloma. 85-year-old, serious nipple discharge. She complained about big spots on her nightgown. Pattern 5. Radiologists are finding these calcifications that you immediately magnify, and then you say, I'm a pattern reader, these are malignant type calcifications. Excuse me. These are within ducts. Look here. Here is the contrast media. It just shows you that these calcifications, which could have been analyzed best here, that are broken needle tip, but broken needle tip should be in TDLUs. No. And so there was the question whether we should send this 80-some-year-old lady to general anesthesia and surgeon and so on. Can we solve the problem? We have to. If she really wants to get rid of the discharge, she has to go to the surgeon. But it makes a difference for the surgeon knowing whether it's going to be benign papillomas or malignant process. Unfortunately, just by looking at a mammogram, I shouldn't say whether it's benign or malignant type. They were seen on ultrasound, and you put the needle in, shoot with the core, and you got a very good result. The calcifications are here. This is hyalinized. This is still viable papilloma. But all this is benign process. No, the mammogram would suggest this is malignant. These are benign papillomas, many of them. Now this made a huge difference for the little old lady. She didn't need to be exposed to cancer surgery. You see, this is what characterizes the benign papilloma. This fiber-elastic core. And then the cells are polarized, looking orderly, so to speak. 47. Serous nipple discharge. That was interesting. Nobody knows what kind of calcifications are these. Fortunately, we got help. Here's a needle, and you do galactography. And now you see that all these calcifications are included within the distended duct and within the filling defects, papilloma. But then we have the next group to talk about. Either nipple discharge is present, or associated calcifications are seen, or both. I'd like to mention to you Peter Power-Rosen used to be a breast pathologist, indeed world-famous colleague, who in 1980 published an article. The main title was the very professional term, juvenile papillomatosis. But then the subtitle was more exciting and everybody read it, Swiss cheese disease. I knew Peter, we were good friends. He visited Sweden, I invited him. And I joked with him, how come that pathologists looking at very ugly specimen think about food? And Peter loved food. Then he encouraged his peers to send him cases. By 1993, he already had 500 cases from different parts of the world. And if I'm not wrong, 2016, there was a further update of the juvenile papillomatosis case story. Dear colleagues, this is the epidemiology. Juvenile means young. Of course, every woman is young, but these are really young. And they run another 60 years to develop breast cancer in case this is a precancerous lesion. 2/3 of the patients are younger than 20. And, unfortunately, some people would call them high-risk cases. Palpable lump? Well, nearly all of the cases. And sometimes nipple discharge may happen. I have a few cases like that. Pain? Never. 28-year-old. 1-year-old child. Gynecologist had palpated a freely movable hard lump in the lateral portion of the patient's left breast. It was an interesting physical examination finding. All these hard lumps gave the impression that you are praying like touching rosary beads. Hard, 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 hard. And fills a whole lobe. The individual foci were calcified, and some of them were hollow. Fibroadenoma is ruled out. It's not calcified at this age. Or if it calcifies, the two kinds of calcifications. But forget about fibroadenoma. These must be papillomas, with those characteristic somewhat hollow calcifications as well. And the surgeons didn't take out everything. 22 years later, still asymptomatic, and the mammogram shows the remainder of the original lesion. Incomplete removal. 23. Hard lump. No discharge. It was really very hard. This teaches you something. The technologists are putting up the BB. Now that doesn't mean that the palpable tumor is right under it. No. In this direction anywhere. It can be here, it can be here, it can be anywhere. And it was. And the hard lesion was architectural distortion. You already learned it. Palpable architectural distortion, cancer. Well, there are the exceptions. And here it is. It's called Swiss cheese disease. What do you mean? This is a tense sign, and this is an ill-defined stellate lesion, and it's palpable. Sure. Just take it easy. Well, we are going to use core biopsy. But at the same time, fine needle aspiration biopsy was done. It didn't show malignancy. Core biopsy showed papillary lesions, definitely not malignancy. Great. We are going to remove this. We are going to remove that. Here is the specimen. And now I start to see calcifications, and they are pretty faint, and they are a little bit roundish. Now let's have an explanation for all this. Dear colleagues, this is characteristic for Swiss cheese disease. Now you understand why Paul Peter Rosen called it Swiss cheese disease. And here it is. This is actually fibrocystic change. Swiss cheese disease is a very localized, focal fibrocystic change. Why is it so hard? Because it's fluid, and it's fluid here, and it's fluid here, and it's fluid here. Fluid cannot be compressed. This is the problem. For my eyes anyway, a good pathologist would say, don't worry, this is just hyperplasia. Cell proliferation, abundant cell proliferation. 27% of cases, that is every fourth case, there is atypia. But this dominates the picture. The holes and the cell proliferation. This is her case. Swiss cheese disease. If you listen to this lecture, I hope you are going to be able to solve a problem, what I'm going to show pretty soon. 40-year-old woman, first screening, she felt a lump in the upper outer quadrant of her right breast for many years and noted serous nipple discharge in the right nipple. Here. Oh, if there is nipple discharge, I'm right there with my galactography needle. And I saw that they are dislocated. The ducts are pushed aside by this, which turned out to be Swiss cheese disease. Calcified papillomas, juvenile papillomatosis. We got a confirmation, no malignancy. 14 years later, patient is still asymptomatic. So the next group, nipple discharge may be present or absent. Tumor mass may be seen. Calcifications may be associated. 68, bloody nipple discharge. What a tricky case. This is the nipple. And beside the nipple, there is a non-specific single calcification until I magnify it. And it's suddenly not. And some of them are hollow. Here is the nipple, and this is a distended duct. Most of the calcifications are inside, some of them are outside. What is going on here? Well, she had nipple discharge. All these are papillomas. But why are these non-specific calcifications kind of outside? Oh, because she has an associated carcinoma. Low-grade carcinoma there. Quite a large area is going to be removed. Here are the calcifications. Some of them are definitely benign type. Some of them don't know. Let's see what they are. Here's the nipple. We go to the tumor board, and here it is. This is the papilloma, benign. But this one is a DAB. It's a cancer. Ionized papilloma. Now you understand pathology. And this part is normal here. But this one is carcinoma. They call it in situ, which is not correct. It's a DAB. Malignant cells creeping along. This was certainly not visible on the mammogram. Pagetoid spread. It has nothing to do with Paget's disease. It's just the cancer cells are creeping inside the major lactiferous ducts. This is answering the question, papilloma, should I operate or not? You have to be more specific. We are talking about without discharge or clinical symptom. So this is what we decided with Dr. Todd. Simulation it's called. Here is the papilloma, which measures about 3-4 millimeter. Because the surgeon always does segmentectomy, what about a tissue 10 millimeter? What about a tissue 12 millimeter from the edge of the papilloma, 15 millimeter, 20 millimeter? Here is the study. This was a poster session at Amelia Islands in Florida. And it really gives you a take-home message. This is the poster, and I'm going to give you the details of this. We had this large biopsy device. We had 140 consecutive surgically removed cases between 1995 and 2003. So then we did this simulation, ever-increasing size of the region around the papilloma, and we were looking for the step wedge, cancer in situ, lobular cancer in situ, atypia, whatnot. And you got the different groups. 94 were benign papillomas, but 14 of them had some epithelial instability. And then there were 11 atypical papillomas, which means that a benign papilloma also has within it cancer cells, atypia. There were 22 malignant papillomas, 13 intracystic papillomas. So now you have a good grip over the material. And so let's focus on this one. 140 minus 80. The 60 had to go to surgery because of atypia, cancer, and so on. We are not talking about this. We are talking about this one now. Answering your question, what am I going to do with the core biopsy-proven benign papillomas? And we followed these cases up. And actually, there was no subsequent occurrence of breast cancer. Half of the expected cancer incidence. So, dear colleagues, the conclusion is, when histology shows malignant papilloma, intracystic carcinoma, and so on, you have to go to surgery. But 80 out of the 140 could have been spared surgery. I hope I gave a good answer to your question. We are cruising towards the end, but I'm showing you a few cases. She had this nipple discharge, I did galactography, and unfortunately I did not appreciate this one, the dislocation. Because I fell in love with the calcifications and all these filling defects. Look how many are they, with and without calcifications. These all turned out to be benign papillomas, but I never forget, it was a polyclinical operation, surgery. The surgeon asked me to come and put rubber gloves on your hand. This was a mucinous carcinoma. What a surprise. It was a palpable lesion. Smart enough, he palpated through the whole breast, multiple foci of colloid and papillary carcinomas. But actually what was seen on the mammogram was benign papillomas, some of them calcified. Mammographically called, nipple discharge is present, no associated calcifications. Nipple discharge present, no calcifications. And the malignancy is an incidental finding. Bloody nipple discharge, lower half of the breast. You see the filling defects. Here's the CC projection, microfocus magnification on the side branch. This is benign papilloma. 50 millimeter long, that's quite something. But adjacent, just beside the papilloma, there was a grade 1 micropapillary carcinoma in situ without necrosis. So you see, that's why not only the papilloma, but a surrounding 1.5 to 2 centimeter has to be removed. Otherwise, you are going to miss these. She had surgical excision. 8 years, 3 months later, asymptomatic, no abnormality. Malignant DAB cases, nipple discharge is present, no calcifications, 53 years old. There is a bump here in the right breast. That's invasive carcinoma. And this is a tense sign, shrinks. I provoke it, it's more expressed. Take it out, stellate lesion, 12 millimeter tubular carcinoma. That's fine. She comes for regular follow-up, and then in the left breast she developed nipple discharge, and the mammogram looked like this. Now this is not very good looking because the ducts are full of filling defects, and here is an invasive tumor, and it goes all the way to the nipple. Everything is carcinoma here. Is there some benign papilloma as well? Might be. But actually it's papillary carcinoma, DAB. 3 nodes are positive. 18 years after right mastectomy and 12 years after left mastectomy, she's still well.